Very good morning to all. Today we'll discuss about sequelae of wearing complete dentures. Okay, so there are two types of sequelae in wearing of complete denture. First one direct sequelae and second one indirect sequelae. Under direct sequelae, mainly denture stomatitis, denture irritation hyperplasia, fibroepithelial polyp, flabby ridge, traumatic ulcer, oral cancer, burning mouth syndrome, gagging, residual alveolar ridge resorption, altered taste, altered speech, angular cheilitis, and galvanism. Under indirect sequelae of wearing complete denture, first one atrophy of masticatory muscles and second one nutritional deficiencies. So now we'll discuss about detail about direct sequelae of wearing complete denture under mucosal reactions. First one, denture stomatitis. Denture stomatitis is a pathological reaction of the denture wearing mucosa. It is also known as denture-induced stomatitis, denture sore mouth, inflammatory papillary hyperplasia, or chronic atrophic candidiasis. Coming to classification of denture stomatitis by Newton, mainly three types: type 1, type 2, type 3. Type 1 is localized simple inflammation or pinpoint hyperemia. Type 2, erythematous or generalized simple type presenting a more diffuse erythema involving a part or the entire denture covered mucosa. And the last one, type 3, it is granular type or inflammatory papillary hyperplasia. It is commonly involving the central part of the hard palate and the alveolar ridge. It is associated with the type 1 or type 2, or it is the combination of the type 1 and type 2. And the picture of first one is the type 1 and the second one is the type 3. So coming to etiology of the denture stomatitis, the main cause is the presence of the denture in the oral cavity, and it is associated with the patients wearing dentures day and night. Second one, denture plaque and the trauma reduce the degree of keratinization and the barrier function of the epithelium that allows easy penetration of fungal and bacterial antigens. Third one, Candida albicans is most often associated with the denture stomatitis along with the other causative factors. It is then termed as Candida associated denture stomatitis. Next is the diagnosis of the denture stomatitis. The diagnosis of the Candida associated denture stomatitis is confirmed by the presence of mycelia or pseudohyphae in a direct smear and or the isolation of the Candida in eye numbers from the lesion that is greater than 50 colonies. Next, the prevention and management of the denture stomatitis. This involves the following measures. Initiation of the effective oral and denture hygiene. The first one, the effective oral and denture maintenance. And the second one, correction of the ill-fitting denture. So correct the loose denture or ill-fitting dentures. And third one, antifungal therapy. So antifungal drugs like miconazole or clotrimazole is preferred to systemic therapy with the ketoconazole or fluconazole. So how to prevent the denture stomatitis or how to prevent the recurrence of the denture stomatitis? So first one, antifungal treatment should be continued for 4 weeks. Second one, patient are instructed to remove the dentures during sucking when lozenges are prescribed. And third one, patient should follow meticulous oral and denture hygiene. So the oral and denture hygiene is very important for to prevent the recurrence of the denture stomatitis. And the surgical treatment, it is mainly indicated for type 3 denture stomatitis. Type 3 is the combination of the type 1 and type 2 denture stomatitis. And cryo surgery also preferred for treatment of the denture stomatitis. So second direct sequelae is denture irritation hyperplasia or Epulis fissuratum. This tissue hyperplasia of the mucosa is a consequence of the trauma of ill-fitting dentures and occurs along the denture borders. It is also known as inflammatory fibrous hyperplasia or denture injury tumor or denture epulis. And this is the picture that shows the denture irritation hyperplasia. Next is the etiology of the denture irritation hyperplasia. Chronic injury due to unstable dentures or thin overextended denture flanges. So the denture irritation hyperplasia mainly due to unstable dentures. Otherwise, other reason is thin overextended denture flanges. Okay. So next is the clinical features of the denture irritation hyperplasia is proliferation takes place quickly, but the symptoms may be mild. It appears as a single or multiple fold of hyperplastic tissue in the alveolar vestibule. Inflammation varies from mild to severe ulceration with deep fissures. The severe form may mimic a neoplasm. The anterior portion of the jaw is more commonly affected than the posterior areas. Coming to management of the denture irritation hyperplasia, surgical removal of the lesion is followed by the adjustment of the old dentures or replacement of the dentures. And next direct sequelae is fibroepithelial polyp. Fibroepithelial polyp is a less common form of fibrous hyperplasia. It is also known as leaf-like denture fibroma. The main etiology is irritation or trauma of the maxillary denture. Next is the clinical examination. It appears as a flattened pink mass that is attached to the palate by a peduncle. It is easily lifted up with a probe. They usually appear as single lesions but may occasionally present as multiple lesions. They are few millimeters in size. Next is the management of the fibroepithelial polyp. Treatment comprises surgical excision of the lesion and relining or remaking of the ill-fitting dentures. Next is the flabby ridge. Flabby ridge is a mobile or extremely resilient alveolar ridge which occurs due to the replacement of the bone by fibrous tissue. It is commonly seen in the anterior region of the maxilla, especially when there are remaining anterior teeth in the mandible. So the flabby ridge is most commonly seen in the maxillary anterior region. They provide poor support to the denture. And this is the picture shows the flabby tissue. The flabby tissue is most commonly seen in the maxillary anterior region. Etiology of the flabby ridge. Excessive load on the residual ridge caused by unstable occlusal force from the remaining natural teeth. Coming to management, surgical removal is an option to improve stability and reduce the ridge resorption. When severe resorption already exists, removing the flabby tissue will completely eliminate the vestibular area. Special impression techniques are indicated for flabby ridge. So many techniques are indicated for the management of the flabby ridge. That is the one of the most important techniques, window cutting technique. Next direct sequelae is traumatic ulcer. Traumatic ulcers or sore spot are a breach in the surface epithelium. They develop within 1 to 2 days after the placement of the new dentures. Okay, so the picture shows there is a overextension of the denture lingually that resulting traumatic ulcer. There is a lingual extension, lingual overextension of the denture that leads to traumatic ulcer. Etiology of the traumatic ulcer. It is caused due to overextended denture, flange, or unbalanced occlusion. Predisposing factors leads to traumatic ulcer is diabetes, nutritional deficiencies, radiation therapy, or xerostomia. Clinical features of traumatic ulcers are small, painful areas covered by a gray necrotic membrane and surrounded by an inflammatory halo with firm elevated borders. Coming to management, correction of the offending denture problem, the ulcer will heal spontaneously in a few days. Symptomatic relief is provided with anesthetic gels. Coming to oral cancer, oral cancer or oral carcinoma associated with chronic irritation from dentures has been reported. The predisposing factors leads to oral cancer is use of heavy alcohol and tobacco and poor dental health. Prevention of the oral cancer. Any traumatic ulcer that does not heal following correction of the denture should be checked for malignancy. Denture patient should be recalled every 6 months for a clinical examination. And seventh direct sequel is burning mouth syndrome. Burning pain in the tongue or other oral mucous membrane associated with normal signs. Burning mouth syndrome is also known as stomatopyrosis or glossopyrosis or stomatodynia or glossodynia. In this condition, the oral mucosa appears clinically healthy. It must be differentiated from burning mouth sensation, where the oral mucosa is inflamed due to mechanical denture irritation. The symptoms often appear for the first time in association with the placement of the new dentures. Coming to etiology, burning mouth syndrome has been associated with several causative factors, which can be broadly classified into local factors, systemic factors, psychogenic factors. So the burning mouth syndrome, the causes of burning mouth syndrome is classified into three factors: local factors, systemic factors, and psychogenic factors. So coming to local factors, undue friction on mucosa from dentures, instability of the dentures, prolonged period of masticatory muscle activity, parafunctional tongue activity, myofascial pain, and the last one, infection or oral candidiasis. An allergic reaction may mimic burning mouth syndrome, but are more related to burning mouth sensation. Coming to systemic factors that cause burning mouth syndrome. First one, menopause. It is the most common systemic factor that leads to burning mouth syndrome. Vitamin B12 and iron deficiencies, xerostomia, diabetes, medication, and Parkinson's disease. And psychogenic factors include depression and anxiety. Coming to clinical features of the burning mouth syndrome, female predilection, especially postmenopausal women, because it is commonly seen in the females. Under female, most commonly postmenopausal women. Symptoms appear for the first time after placement of the new dentures. Gradual onset, pain begins in the morning and increases through the courses of the day. Patients complain of a burning sensation associated with a feeling of dry mouth and persistent altered taste sensation. Other symptoms include headache, decreased libido, insomnia, irritability, and depression. Aggravating factors are tension, fatigue, and hot or spicy foods while sleeping. Distraction and eating reduce pain. Coming to management, denture should be checked thoroughly for any local cause and corrected. Any comprehensive treatment may need the help of a psychiatrist. Coming to gagging or retching, the gag reflex is a normal, healthy defense mechanism which prevents the foreign bodies from entering the trachea. Sight, taste, noise, and psychological factors can also produce gagging. In sensitive patients, gagging is common immediately after placement of new dentures, but disappears in a few days as the patient adapts to them. Coming to etiology, overextended denture borders, mainly posterior part of the maxillary denture and distolingual part of the mandibular dentures, unstable occlusal conditions, increased vertical dimension of occlusion, restricted tongue space, gastrointestinal tract disorders, adenoids or discharge from upper respiratory tract, and the last one, alcoholism and smoking. Management of the gagging is the cause has to be identified and corrected. So mainly correct the extension of the posterior border of the maxillary denture and the distolingual portion of the mandibular denture. Coming to next sequelae of wearing complete denture is direct sequelae is residual resorption. Residual resorption may be inevitable due to disease atrophy. It can also be caused due to excessive force transmitted through dentures because of continuous denture wearing and unstable occlusal condition. Next one, altered taste. It is a condition characterized by alteration of the sense of taste may range from mild to severe. Etiology: covering of taste bud in the hard palate by the dentures, ill-fitting dentures, poor oral and denture hygiene, dental disease, olfactory deficit, neurological deficit, and other systemic disorders. Management: the patient must be advised to maintain good oral as well as denture hygiene, and any defect in the denture is corrected. Next direct sequelae is altered speech. Difficulty is to be expected when the complete denture are first worn. However, the adaptability of the patient is sufficient to attain adequate speech patterns. Temporary alteration may be due to thickness of the denture base covering the palate, slightly altered tongue position, copious salivary flow. These difficulties can be overcome by asking the patient to practice speaking with the dentures by reading aloud. Etiology: persistence of phonectic problems may be due to an alteration of the position of the maxillary incisors and changing in their palatal shape, reduction in tongue space, alteration of the occlusal plane, defective palatal contour, and the last etiology is improper posterior extension of the dentures. Coming to management of the altered speech, correction of the offending problem if possible, but most often a new set of dentures will have to be fabricated with a sound knowledge of the valving actions of speech and keeping in mind the principles of the teeth arrangement. Next one is the angular colitis. Angular colitis is a multifactorial disease affecting the commissure of the lip and commonly seen the denture wear. The most common site is commissure of the lips. It is also called perlechi when it is associated with the nutritional deficiencies. Etiology of angular colitis is loss of vertical dimension, nutritional deficiencies such as iron deficiency and vitamin B deficiency, and other predisposing factors are AIDS, diabetes, and neutropenia. Management of the angular colitis: the primary cause should be treated first. The patient vertical dimension should be restored. Antifungal agents and antibiotics can be given to treat the secondary infection. And the last direct sequelae of wearing complete denture is galvanism. Galvanism is due to the presence of different types of dental materials, mostly metals, in the mouth, which cause electrochemical corrosion. This galvanic current may be a cause of burning mouth syndrome, oral lichen planus, and altered taste perception. So next one, indirect sequelae. So direct sequelae of the wearing complete denture is over, and the next one, indirect sequelae of complete denture wearing. And the first one is the atrophy of the masticatory muscle. So what is atrophy of the masticatory muscle? Masticatory function depends on skeletal muscle force and coordination of oral functional movements by patient. In general, bite force decreases with age. A greater reduction has been demonstrated in complete denture patients, especially in women. In fact, complete denture patients need 7 times more chewing stroke than person with a natural dentition to achieve similar reduction in particle size. Retaining a few teeth to support over dentures and implant support dentures has improved the maximal occlusal force and masticatory efficiency of completely edentulous individuals. And the second indirect sequelae is nutritional deficiencies. Severe deficiencies are rare, except in hospitalized or chronically ill patients. In such patients, ill-fitting dentures, salivary gland hypofunction, or altered taste perception may have a negative effect on the nutritional status, and some improvement in nutritional intake can be expected following prosthodontic correction. So, and this is the direct and indirect sequelae of the wearing of the complete denture. So, the today class is over. I hope you all understood the topic. Thank you.